Okay. Good morning. So I have the pleasure of talking about a cell that has really been kind of like the Rodney Dangerfield of the body for like 100 years. And really has come to the forefront just within the past, I would say, 10 years, which means that the rest of the medical community will figure it out in another 10 years. But many of us are living with mast cell-mediated disorders. It's just a question of whether or not it's mast cell activation syndrome. And so we're going to talk a little bit about what mast cell activation syndrome is, and then how you can get it under control. So you got to ask yourself, do you have mast cell activation syndrome? And this kind of tells you all the different types of symptoms that can happen because mast cells are actually living in every single organ, whether it's your skin, your gut, your brain, your spleen, your joints. And if they are inappropriately activated, it's kind of like calling the police and the SWAT team into your neighborhood because you have a cat in the tree. So there are lots of mast cell-mediated disorders. It's anticipated if you're living in an urban or industrialized country, 1 out of 2 of us is experiencing some type of mast cell activation issues, whether or not it's nasal congestion, and you have asthma or asthma-like symptoms, IBS, and actually neurocognitive impairment. And what's even more startling, a report just about 2 years ago identified that at least 1 out of 50 of us have had an anaphylactic event. So why are we seeing such a huge rise in these hypersensitivity issues? A lot of it has to do with the fact that we have dramatically changed our environment within the past 20 years. So we're going to say, life before plastic and life after plastic. We spend much more time indoors. We have less control over the food we eat. We have even less control over the air we breathe or the substances that land on our skin. And this has really caused the genes that we've inherited from our ancestors to be completely confused. Barring this from the multiple chemical sensitivity practitioners, basically you have individuals that are susceptible to insults from the environment, whether you're talking infectious. The most one that's gotten the attention right now is Lyme, and how that has actually opened the door to a chronic hypersensitivity disorder. You might have seen the article in the New York Times where they talked about meat allergy. So these are individuals, when they develop Lyme, and then they end up with a delayed hypersensitivity reaction. So here you have an infection that opens the door to a chronic hypersensitivity disorder. And then upon reintroduction of other different types of triggers, basically your immune system just does not stand down. So we've noted that in the allergy immunology community that anyone, young or old, and now we're starting to see adults and seniors, or seasoned, as I like to call myself since I have my AARP card, are now susceptible to having mast cell-mediated inappropriate activation impacting different types of cell systems. And unfortunately, a lot of these individuals end up having delayed diagnosis because internationally we have a shortage of allergy immunology specialists, and just in this country alone, we have 77 training programs. Out of those 77 training programs, only 3 do research on mast cells. So we have a lot of individuals who are just not trained on how to recognize and then diagnose and treat these mast cell-mediated disorders. And because there's such a delayed diagnosis, partly because patients have a tendency to kind of focus on individual symptoms, so you end up going to that particular specialist. General practitioners are ill-prepared to appreciate immune-mediated disorders because they got one lecture on mast cells 20 years ago. And so a lot of these individuals end up, the tests are normal or the tests are not ordered. And so because it's not measured, it doesn't exist, so you have individuals that really end up being sick, and then practitioners have a tendency to kind of be, if you're lucky, they're dismissive, and sometimes they actually can be quite harmful when dismissing and actually start doing treatments that are inappropriate and actually cause more damage to heart. So it's not unusual for a lot of individuals that have mast cell-mediated disorders to have comorbid psychiatric illnesses, partly from the disease itself and also partly because of the lack of responsiveness from the medical community. So the best way to kind of start learning how to take care of mast cell disorders is to ask yourself, do you have a mast cell activation syndrome? And here are just some examples of patients that have come through our practice. And typically, you have to have at least 2 organ systems that are impacted that will suggest that mast cells are dysregulated. So you can have skin and gut involvement, you can have nasal congestion and headache syndromes. You know, it's that combination that will say, okay, should we start looking at seeing whether or not mast cells are misbehaving or not? And then there are 3 criteria that have been put out, and we're still working on this, but essentially 3 questions. Do you have signs or symptoms worrisome from mast cells misbehaving? Do you have medications such as over-the-counter antihistamines? You have Benadryl, Claritin, Allegra, Zyrtec, Zantac, Tagamed, Pepcid, or prescription medications such as Cromolyn or Singulair, and you show modest improvement of your symptoms. That is suggestive that you might have a mast cell activation syndrome. And then what data do we have to support that your mast cells are misbehaving? And I'll talk a little bit about the roadblocks for each one of these criteria, but I'm just going into a little bit more detail about each one. So it's going to take a coordinated team. So you really need to identify a practitioner who's willing and able to work with you, will not dismiss your symptoms, won't say that this is, you know, somatic disorder, conversion disorder, or, you know, it's just allergies. And then coordinate this other specialists that are going to be involved in your care, because more than likely you're going to need gastroenterology, neurology, psychiatry, dermatology, urology, because again, if mast cells are misbehaving, they really can cause problems in all of those organ systems. So the first question is, do you have mast cell activation syndrome, or GOT MCAS? And then once you identify somebody, I'm hoping that this talk will provide you with some questions that you can work with your practitioner to try to navigate the very convoluted, complicated maze of the healthcare system in order to find out whether you have mast cell, and then figure out what medications or treatments can be helpful to you besides just avoidance, which I have to tell you, tolerance is not free. So you really need, in order to restore tolerance to what you eat, what you breathe, what lands on your skin, it's really important to kind of reduce the stress of your body so then you can then develop tolerance to these exposures, even temperature. So I kind of borrowed this from the asthma world, where it's important to step up to your next checkup. And basically, you want to screen for symptoms or signs that are worrisome from mast cells misbehaving. See whether or not you have any risk factors. It's not unusual. I can't tell you how many parents bring their kids in and they're going like this, or they're telling me that they're bloating. I had one mother actually take over the appointment of her daughter, and the daughter pushed back. This is my appointment, Mom. But typically, this will run in the generations as well. And then you also have to kind of look at what kind of risk factors you have, even in the environment that you grew up in. Then I'm going to go into some of the tests that are available. Unfortunately, we have very few commercial tests available to identify mast cell dysregulation. But even with those tests, we might be able to figure out whether or not your mast cells are misbehaving or not. And then the next idea is to kind of just educate yourself about this condition and how it can interact with other organ systems. So it's not unusual, especially in the Ehlers-Danlos community, that if you have mast cell dysregulation, it's very possible that you're also going to have a connective tissue disorder and also a neuropathy. So it's not unusual for patients that come for an evaluation through our practice that we do a referral to a neurologist who's knowledgeable about peripheral neuropathies, a gastroenterologist who's aware of the fact that mast cells are a major contributor to irritable bowel syndrome, and we also have input from otolaryngologists as well, because getting that upper airway under control is key for sleep disorders, headache disorders, TMJ. and also just reducing and also being able to obtain tissue to try to get the diagnosis of mast cell activation as well. So it is a patient practitioner partnership where you want to get the best working diagnosis. You want to try to maintain normal function as much as possible. You want to optimize therapy, whether you're talking about prescription medications, over-the-counter medications, adjuvant interventions such as chiropractors, functional neurologists, acupuncture, and I know I'm missing a wonderful lecture right now about medical cannabis, but there's a role for all of these treatments depending on what's causing your mast cells to be overactive. And then the goal is really for you to have, eat well, sleep, rest, be able to exert yourself, and maintain function as best as possible. And then after all these things, you need to ask yourself, am I satisfied with the care that I have? Is the relationship that I have with the practitioner helpful? So here's the checklist. Do you have symptoms and signs worrisome from mast cells misbehaving in at least 2 organ systems? Do you respond to medications that target mast cells or mast cell mediators? And then what test results do we have to support that mast cells are dysregulated? So this is just another way of viewing the fact that these are the various organ systems and the manifestations of mast cell dysregulation that can cause gastrointestinal symptoms, neurocognitive impairment. And actually, if you look at patients that have a much more common or well-known form of mast cell activation disorder, which is mastocytosis, these individuals will present to a practice either with skin symptoms or gastrointestinal symptoms, but the third most common complaint isn't anaphylaxis or rhinitis. It actually is neurocognitive issues, mood disorders, difficulty concentrating, difficulty thinking, short-term memory deficits, anxiety, depression. And so it's really important to understand that, and we need to kind of develop short screens for general practitioners to try to evaluate whether individuals are having neurocognitive issues as well, as opposed to just prescribing a SSRI or medication and ignoring the rest of the symptoms and getting an accurate diagnosis. So to kind of give you an idea of all the different factors that are released by mast cells, depending on what organ system they're in, tumor necrosis factor, platelet activating factor, these are all things that can influence how your blood cells are working, how your brain is working. It can cause joint inflammation, gastrointestinal distress, and so a lot of the treatments are actually going after the factors that get elucidated or don't get elucidated when the mast cells are triggered. So when it comes to measuring mast cell activation factors, like I said, there's very few commercial tests available. Essentially, we have urine tests, so 24-hour urine collections, which are not that much fun to collect. And then once you collect them, you have to hope that the technician doesn't leave it on the table while they're getting a cup of coffee, and then shipping it off properly to Mayo or ARUP in California. We have blood tests, histamine, as well as tryptase. Many of you may have had the tryptase measured, and they say that that's normal. That's not the way to approach it. You have to treat mast cell activation syndrome like when we check blood tests for individuals that are having heart attacks. You want to get a baseline, and then if you have an acute event, you want to check the tryptase within 4 to 6 hours of an acute event, and if it goes up 2 points plus 20%, that is diagnostic for mast cell activation syndrome. And then, to be honest, the best test is actually going into the tissue where the mast cells are potentially causing the problems. So understand that mast cells are not blood-borne. They're only found in the tissue. So it's important to kind of get a biopsy. So if you had an endoscopy or a colonoscopy, to let the gastroenterologist know that the pathologist should be staining for the mast cells. They should count them. They should see whether or not they're round or spindle-shaped. And then they should also see whether or not they're clustered or have upregulated activation markers saying that these cells are just not standing down. Oops. And then as far as treatments, most of the studies that have been performed have focused on histamine blockers. But understand, histamine is just one of the factors that gets released by these cells. And on some occasions, histamine doesn't get released at all. So we have histamine blockers, of which we have the first that work on the first histamine receptor, like Benadryl and Zyrtec. We have those that work on the second histamine receptor, which are classically known as heartburn medications, such as Pepcid and Zantac. We have medicines that are more known for asthma, such as Singulair and Accolate and Zyflo. We have Massal stabilizers, such as Ketotifen, Cromolyn, as well as, just went out of my head, omalizumab. And omalizumab is actually interesting. It was the first biologic that was used to treat asthma back in 2003. It's now indicated for asthma and chronic hives. I had one patient who I wanted to prescribe this medication to, and she didn't have asthma. She was mostly complaining of GI distress and headaches, and I asked her if she itches, and she said, it doesn't bother me, and I'm like, that wasn't the question. I just need to know whether you itch or not. And I said, if you itch more than a couple of times a week for the past few weeks, that is actually indication to prescribe this medication and see whether or not it'd be helpful for their symptoms or not. Unfortunately, when it comes to having different organ systems involved, we have a tendency to kind of go to various practitioners who have a tendency to focus on their little corner of the sandbox. And that's why, another reason why individuals that have mast cell dysregulation end up having very delayed diagnoses. The average time to diagnosis for some of these immune-mediated disorders can be up to a decade. So one of the first roadblocks really is the fact that we have a tendency to have general practitioners that have been poorly educated on the immune system. And then we also have practitioners who really just kind of focus on their area and say, this is IBS, or this is anxiety, or this is a sleep disorder. And because no one's talking to each other, no one's coordinating the care, individuals end up coping with these symptoms and more than likely get progressively worse just because of the lack of intervention and recognition of those symptoms. The second delayed diagnosis is a lot of practitioners just don't know how to use the tests that are available for identifying individuals that have a mast cell activation disorder. I'll share the story of a patient that I had been taking care of for about 3 years, and she had chronic hives, and her tryptase was 2 or 3 that I repeatedly checked. And she had been dealing with IBS for 20 years and failed to tell me that until I saw that she was taking medication, Linzess, on the electronic medical record. We went ahead and did an endoscopy, which she hadn't had in 10 years because there's been no change of her symptoms, and she had more than 90 mast cells per high power field. So it really is important to kind of revisit and try to go at a different angle to see whether or not you can identify whether or not someone has overactive mast cells or they have too many mast cells that may be contributing to their symptoms. So the other thing I want to point out is individuals that normally have a normal tryptase, it may be indicative that the sensor that is causing the mast cell to be overactive does not require tryptase. For instance, we have individuals who have food-induced anaphylaxis to peanut, and I can check a tryptase all day long and it'll never be elevated. It doesn't mean that this person doesn't have anaphylaxis or food-induced allergies. It just means that there are other receptors that might be causing the mast cells to contribute to that reaction. And this is, again, emphasizing it's really important to kind of look at what chemicals might be released that would be suggestive that mast cells are overactive. So this is just an illustration that if you have antibodies against pollen or mold or bacteria, you may see tryptase or histamine released. But there are a set of receptors that a lot of practitioners are not aware of called toll receptors. And if the mast cell sees a bacteria or a virus through the toll receptor, they'll try to control that infection through other things other than histamine and tryptase. So again, it's really important to kind of look at the blood on different occasions, look at the urine on different occasions, and then biopsy the organ, whether it's the gut, the nose, the skin, to see whether or not the mast cells are overactive or not. And then the last criteria, whether or not you respond to medications or not, really has to kind of focus on the quality of the medications, and whether or not the mast cells are being called into action appropriately or not. So this is the back of a Benadryl bottle, and you can see there are lots of different ingredients in there. Back in the 1970s, the FDA approved even preservatives and fillers to be added to baby food, so it can sit on the shelf for a year. So it's not unusual for several of the patients that I care for that they get their medications compounded in order to reduce exposure to soy and corn and milk that's added as a binder agent to a lot of these food, medications that are either over-the-counter or prescribed, and also to kind of just reduce their exposure to coloring as well. I'm still shocked that Benadryl is as violently pink. Well, actually I like pink, but it's very pink, and that can be a bit of an issue as well. God bless you. The other issue is the fact that mast cells actually have a job to do. So before styrofoam and plastic and super stop and shop and highways being 500 yards within your roads, their job was to protect us against infectious challenges, toxic challenges. They're essentially the original border patrol. And then after the insult was quelled, their job was to help coordinate the healing process, which I think is an interesting thought in individuals that have connective tissue issues. Understand that mast cells are really important for help coordinating wound repair. And so it's a question of individuals that have connective tissue disorders. Is the connective tissue disorder causing the mast cell dysregulation, or is there a possibility that the mast cell population is contributing to a diffuse connective tissue disorder? So once you think you have a mast cell disorder, unfortunately, a lot of my allergy immunology colleagues have a tendency to say, your skin testing was negative, and your blood tests to pollen and food and medications were negative, that allergen-specific IgE. But thinking that IgE is the only way that your mast cell is activating, it's kind of like the thought of the police officer that's guarding your neighborhood has a single mugshot, and that's the only way that they can tell that this person might be dangerous to you. There's lots of different receptors on these cells, and depending on how these cells are being tickled, may be an indication of why your mast cells are misbehaving. As an allergy immunology specialist, I've been taking care of individuals with chronic hives for 20 years, and I'll stand up and say I'm also a president of that club because I've been dealing with cold-induced hives for 20 years as well. And I can tell you that, if my hives, if I'm not having any hives, that tells me that I'm actually copacetic. But if I see a change in my hive pattern, it's telling me that something's happening, whether I might have a respiratory infection, I might be in a hotel conference room that's really cold. But there are lots of different ways that mast cells can be tickled. These are just some of the conditions that can be associated with increased mast cell activity and dysregulation. And I can tell you the top column, when it's allergies or autoimmune urticaria, which means literally another part of your immune system has decided to attack your mast cells. Histamine blockers might work, but for all these other conditions, you have to have other interventions. So once you get the diagnosis of a mast cell activation disorder, it's really important to sort out what flavor of mast cell activation disorder you have. What is most well known by healthcare practitioners but is rare, less than 200,000 cases worldwide, are individuals that have mastocytosis or what's called mastocytosis junior, monoclonal mast cell activation syndrome. Then you have individuals, and I think this is really important because this is the first time it has been identified that an enzyme that's only found in mast cells that can cause a diffuse connective tissue disorder. So individuals, and there's a company here, Gene by Gene, that can do the evaluation. Individuals can inherit a duplication or triplication of this gene. So every time that mast cell is triggered, you're releasing 2 times or 3 times as much tryptase. And individuals, and this was an observation from Joshua Milner at National Institutes of Health, they will end up with the trifecta of a connective tissue disorder worrisome for hypermobile Ehlers-Danlos syndrome. They'll have dysautonomia in the form of POTS, and they will also have hypersensitivity to allergic and non-allergic triggers, or Massal activation syndrome. But the majority of us, the mast cells are being inappropriately called in. It's kind of like your police officer being called on 911 because your dog is barking at your sister. I don't know. So, but it's really important to understand what is tickling the mast cells to increase their activity. And so when individuals, once I try to identify whether or not mast cells are overactive or not, I try to figure out why. And in this community, the one thing that's extremely common might be what's called dermatographism or dermatographia, where you have the ability to write on your skin and it turns into a hive. So that is a classic marker for individuals that have mast cell activation issues. And then I'm also labeled this, I'm an idiot, I can't figure it out. But we still have individuals that have idiopathic anaphylaxis, and there's more research to be done. So again, do you have mast cell activation syndrome? What flavor do you have? And so as an allergy immunology specialist, I have to be grateful to the practitioners in this community. I've learned how to do bite-in screens, and when I presented this to the American College of Asthma Allergy Immunology, the 10 people that were in the room for that talk, basically said, what, we have to start bending people to try to figure out whether or not they have they have a mast cell disorder? I'm like, yes, you do. So these are the battery of tests that I have a tendency to order when patients come through to see whether or not they have a secondary Massal activation syndrome. So allergy testing is important. You don't necessarily need to go for another endoscopy or colonoscopy, although I did just meet a patient. I don't know how the gastroenterologist got this paid, but she had 9 colonoscopies in 10 months. You definitely want to do a rheumatology panel, whether or not this is rheumatoid arthritis or rheumatoid arthritis light, or I think what the rheumatologists call seronegative rheumatoid arthritis. You want to check for autoimmune antibodies against the thyroid. I think the thing that's really important is to start checking for antibodies against the peripheral nerves. And it's important to identify a neurologist that has expertise in looking for small fiber neuropathy. Definitely screening for Ehlers-Danlos syndrome or connective tissue disorders. And I'm just going to briefly talk about some of the research that we've done looking at patients that have come through. We've actually identified individuals that have immune deficiency, and their symptoms are hypersensitivity reactions. If they have a history of infections, recurrent infections, or severe infections, it's remote. But this is where your history and you taking note of your journey is really important to try to identify not only that you have a mast cell activation issue, but it's a deficiency in another component of the immune system that might be driving it. So I don't know, you may have seen these signs. I've seen this once, actually, when I came down to the meeting in Houston. Is it just a cold? So these are the 10 warning signs for looking for primary immune deficiency. Recurrent infections, 2 pneumonias. I actually had taken care of a woman as a fellow who had 20 pneumonias in 25 years. And the only reason she came to our attention is because her pulmonologist retired. And it turned out she had a form of immune deficiency called common variable immune deficiency. And now has bronchiectasis because she was improperly diagnosed. So if you're having sporadic infections, recurrent infections, if you have autoimmune disorders, interestingly enough, you can actually present with autoimmune hair loss, thyroid disorders, diabetes. This may be a sign of you lacking a component in your immune system, either in the cell or the proteins that might be causing that to be happening. And then also, some forms of malignancy are also associated with immune deficiency as well. So in the past 2 years, I had the pleasure of a young lady who came up from Chile, and we actually went through charts, and we identified individuals that had mannose-binding lectin deficiency, idiopathic CD4 lymphocytopenia, and antibody deficiencies. And their complaints, again, wasn't infections. It was recurrent, it was hypersensitivity disorders. So basically, there was a loss in the check and in the immune system. And, you know, the analogy I commonly use with a lot of patients is, you know, if your house is on fire and the police show up, would you be upset with that? And you'll say no, but the police officer doesn't necessarily know how to put out the fire. And if they start to help, they could potentially make the situation worse or get themselves hurt as well. So this is what the mast cells are doing. They probably are compensating for the lack of a protein or a cell that's much more effective in dealing with that infectious or toxic challenge. And because we're in an environment where we're being increasingly exposed to chemicals that are considered toxic, whether naturally made, such as mold, or artificial in the form of off-gassing from newly manufactured materials, the mast cells are not standing down. So in these individuals, the treatment for mast cell activation syndrome, how to live better, feel better, is you need to identify whether you have a mast cell disorder or not, and then you need to figure out what's causing those mast cells to be dysregulated. If it's allergies, these are the recommendations, avoidance measures, and especially with diet, and a lot of patients have a tendency to focus on what they eat, and my response to that is important. You eat maybe 4 or 5 times, well, if you have dysautonomia, 6 or 7 times a day. You breathe 18 times per minute, and your skin is constantly exposed to the environment. So it's really important to have a much more comprehensive approach regarding modifying your environment, and understand when you continue to modify your environment, you kind of start losing the ability to develop tolerance as well. If you have susceptibility to infections, whether it's sinus, pneumonia, or chronic Lyme, or Borrelia, or Candida, or herpes virus, it's really important to try to understand whether or not you have an immune deficiency that's contributing to that. And then you need to kind of focus on the treatments. We've identified 2 individuals that actually had hepatitis B, and treating the hepatitis actually got their hypersensitivity disorders under control. And then also, we have plenty of medications, and more are coming regarding treatment of classic autoimmune disorders, whether you're talking about rheumatoid arthritis, or psoriasis, or Crohn's. Interestingly enough, we have at least 2 patients where I've used Rituxan in order to get their immune hypersensitivity issues under control as well. So, in many ways, I'm going to encourage you to be like that mole and try to focus on, if you're having little things, to get that evaluated before it becomes a big thing. We have a tendency to meet patients when they're completely debilitated from mast cell dysregulation, which is associated with, not as commonly associated with having a nerve involvement, whether it's in the form of small fiber neuropathy or chronic immune demyelinating polyneuropathy as well. And I'm of the ilk of it's better to forestall disaster than treat it. I have many patients who come through complaining of headaches and congestion issues. I will screen for asthma. If they, or as well as gastrointestinal symptoms, because understand a lot of the throat symptoms can be postnasal drip, or it could be laryngopharyngeal reflux. This is just contents of the stomach making their way to the throat as well. So when you start to meet up with your practitioner, and try to do it in small bites, because I have one patient who showed up with her history, which was 8-point, back and front on 5 pages. It's a lot to take in, but I can appreciate that because, I shared with you that I've had chronic urticaria, but if it wasn't for my participation and being welcome to speak here, I would have been able to diagnose my daughter who has this as well, regarding the Ehlers-Danlos and mast cell dysfunction. So it's really important to kind of, if you're working with a practitioner who's not taking you seriously, then you need to identify another practitioner who will. And so I'm going to kind of finish off with this comment from Polly Matzinger, who has an incredible story. So if you ever have time, this is a woman who started as a cocktail waitress in Scripps, and now she heads a major division of National Institutes of Health in the Allergy Immunology Division. She's the one who basically said that this is not a question about having positive antibodies. I can go out right now and test 100 people for an antibody against peanut. The interesting question there is 12 people out of the 100 will have a positive test, but only 2 out of the 12 will be symptomatic. So 2 lost tolerance, but 10 maintained tolerance. And so if we can figure out how the individuals lost their tolerance, or more importantly, how the 10 retain their tolerance, which definitely involves reduce of stress, whether it's in dealing with infections, change in climate, what have you, we'll be able to try to restore the balance that you're going to need regarding Massal focusing on what they need to go after and ignoring changes in temperature, airborne fresheners, whether or not the food that was cooked the day before has broken down and now has chemicals in it that might be irritating you. And with that, these are the steps to feeling better, and I'm going to say salute, and I'm happy to take questions, or shall I wait till later? Good? Fabulous. Well, thank you for your attention. I appreciate your efforts.